I'd like to just throw out a couple of questions. First of all, from our industry colleagues, I'm impressed that that we have GSK, Bayer, Novartis seems to have a commitment to Chagas disease, and which is a pleasant surprise given that there's not much of a bottom line for Chagas disease in terms of financial impact on the company. So my question is, what does that dialogue look like with your bosses? What do you have to do to, one, persuade them to continue commitments to Chagas disease? Is it an uncomfortable dialogue? Is it a joyful dialogue? And where do you see it going? Do you see it continuing as is, expanding, declining? As candid as you're willing to be.
Well, they said ladies first. I was going to defer, but
we're not competing.
That's all right. No. But ours have been good dialogues. Our focus, as I said, are children, and we really strongly believe if we can cure the children, we won't see them in the adults. That Dr. Shiba will not have them, and other clinicians won't have those patients to have to deal with. But given that it's a focus on the pediatric age group, we have very little resistance from our management, total cooperation. We feel it's a part of our corporate responsibility to do whatever we can to treat and cure the children.
Well, in Novartis, we have a clear separation between the commercial side and the scientific side. So I think the interest will keep it existing. I think it's part of the corporate responsibility. We have also a Novartis foundation that it's very, very focused on neglected diseases. So I think it's an easy conversation, to be honest, because I think they perceive the value of keeping investing in these neglected diseases, and there is no commercial interest. They know that. So.
This is Peter Hotez. I don't know if you've heard my question, which was, we're asking that it's impressive that we've got so much industry commitment to Chagas disease, and I'd like your perspective on how it is with your bosses to continue to persuade them to roll the dice with you on Chagas disease, continue that commitment. Is it an uncomfortable dialogue? Is it an easy dialogue? What does that look like for you?
Yeah, I mean, this effort was born with the aspiration of being sustainable on the time. So we're going to develop a new medicine. We know what's the turnaround, the life cycle for developing a medicine, which is 10, 15 years. So this was born with that aspiration. So we want to keep the dialogue, the collaborations with the different partners. So this is a small world, so there's not many funding out there. So I want to be a key player there. As I said, it's bringing what we know how to do, rather than displacing the effort by anybody else. We don't have an aspiration of being the owners of our projects, so we co-own our projects. The main challenge for us is access to clinical trials, in particular for Chagas, and it's something that maybe we struggle, in particular because it's very difficult to the translation from preclinical models to animal to human diseases and patients. So it's a high risk venture. So and then this is something that we are not going to pursue alone. So that's our aspiration.
So, just in case you thought I was going to let you all off easy, I'm going to now ask DNDi, represented by Dr. Forsyth, what are you looking for from industry? What are they not doing that you need, or are they meeting all your needs, other than the obvious, which is, as someone who heads a product development partnership with money, what is it that you're looking for from industry that is not currently available to you?
That's a tough question. I mean, our organization relies a lot on industry partners. So I don't know if it's fair to blame all of the deficiencies we have right now for medications in Chagas disease strictly on the industry. I mean, I think there's a whole host of factors. I mean, perhaps in the past, the lack of development of new medications could be tied to some of the market logic of the lack of profitability in patients with Chagas disease. But I mean, I think the fact that we have all of these representatives here shows us that logic is changing and that there is increasing industry interest, and we're certainly excited to work with industry and any other partners to meet this challenge.
Terrific. Let me ask Santiago first, but then I'm going to ask the others as well. One of the themes that we heard this morning over and over again was lack of access to medicines, that we're hearing 1% or less of the world's sufferers of Chagas disease have access either to benzoyl or nifurtimox. So from a PAHO perspective, what do you see as the big roadblock there, and what would you like to
Well,
see?
we think that that's a very good question, actually. We think that there are some of the factors that are associated with lack of access to drugs. I mean, not only to the drugs for treatment of Chagas disease, but also to the treatment for, let's say, the symptomatic treatment for the Chagas cardiopathy, for example, are related to the health services. So, to barriers in the access of people throughout Latin America to health services because of different reasons. I mean, the populations that suffer from Chagas disease are mostly populations that live in rural areas or in urban marginalized areas that don't have the means to pay or have barriers to access generally for healthcare, and that includes also barriers to of access to care for Chagas disease. So we have been working with the Department of Health System and Services at PAHO to try to see how we can solve these barriers, because it's actually not the responsibility of the Chagas disease control programs to solve these barriers, but it is more an issue of the general health services. So how can we get, for example, the people that are suffering from Chagas disease to have real access to primary health care, and also, when needed, to specialized health care for management of their chronic heart failure or other symptoms. I think that's the main issue. The other, regarding the specific drugs for Chagas disease, as was mentioned, there is an agreement between WHO and Baylor for the donation of several million tablets of nifurtimox for several years, and we offer these drugs, of course, free of charge for the for the countries and for the Chagas disease control programs. But what we do is that every year we ask them, the countries, to give us their estimates of the drugs they will need, and then when we get the drugs, we'll distribute them to the countries as they indicate us. Unfortunately, I think one of the other issues that is happening is that not all the healthcare professionals, or maybe most of them in the endemic countries, know about the specific treatment for Chagas disease. I mean, in fact, in many cases, they even might not suspect Chagas disease nor diagnose it, but even when it is suspected and diagnosed, they don't know how to properly manage the cases, and at the end, they don't know that these drugs, for example, nifurtimox, is available free of charge for treating the infected patients.
So let's do a little deeper dive here. So when you talk about depleted health systems and lack of health services, I understand that argument works for Bolivia. I understand that argument works for Paraguay and maybe some of the Central American countries. But Argentina, Mexico, Brazil, these You're saying that, I mean, I think that, presumably they have a fairly sophisticated system in place for creating health services and health systems. And yet and the medicines are being donated, and yet we still have fewer than 1% of people having access to diagnosis and treatment. So how do we fix that?
No, there is indeed, as you say, a lot of variations, and of course Mexico, Argentina, Brazil, I would even say Colombia, my country, have fairly strong health services, but even then there are some barriers. And also the lack of knowledge in the medical, in the physicians and the healthcare staff eventually might impair the access of patients to proper treatment and proper care for Chagas disease.
By the way, if you think I'm picking on Argentina, Brazil, and Mexico, I would add the United States as well. Right? I put them in the same category.
So, I mean, I think it indeed has to do with several factors, and some of these I've mentioned. There are probably others, but yes, it's a difficulty and it's a challenge that we need to try to overcome.
Let's ask. So, do you have questions from the audience? Yes, and also identify yourself.
Yeah, if you just say your name and affiliation.
So my name is Clive Schiff, and I'm from Johns Hopkins University. But from my accent, you can probably tell I'm not from America. I'm actually from Zimbabwe, and I've got some questions that I would like to put to the group, because I followed Trypanosomiasis rhodesiense in my own home country, and the really great success that's happening in HAT control is the vector. Vector control is being very effectively applied over most of the area now, and the disease is declining. So my question is, we have a deficiency, I think, with Chagas in two areas. One is diagnosis, because the current diagnosis is serological. It's very difficult to define to find the organisms themselves. But there are other methods that we're trying to develop ourselves at Hopkins. But my own personal thing is that you can find DNA from these parasites in urine, and this is something that we've been able to establish with strongyloides and with schistosomes, and so I think this is there's venues for better diagnosis. And the other thing is, I'd like to mention something about Bayer, because in controlling schistosomiasis in Africa years and years ago, Bayer was the main provider of molluscicides to control snails and the drugs to treat the infection. And I wonder if Bayer would be expanding its work again to look at the vector and the vector and its transmission, because I think the second deficiency that it occurs to me is that we aren't looking at the vector, and this is a vector-borne disease. Chagas is very much related to the distribution of the triatomids, and we need to know more about controlling triatomids. So is there some way that industry will be looking as much towards the improved drugs as it is to perhaps enhancing vector control and better diagnosis?
Well, as I said, Bayer does have an environmental science division, and vector control is one of the focuses there, so that's something that we can certainly take back to them and have them take a look at. They could be looking at it. I'm not directly connected to them in the clinical development area of human clinical trials as opposed to animal studies and so forth. But certainly vector control is one of the areas that we believe very strongly in, that should be a part of the whole therapeutic approach in controlling and eliminating Chagas and other conditions as well.
I think that vector control is very important indeed, but as I showed in the slide, actually in vector control there has been a lot of progress. One of the criticisms that we received was that we were very much focusing on vector control and not on the patient. Now we're focusing much more on the patient than we used to do before, because vector control was a huge success. You know, the vector-borne transmission of Chagas disease by Tratoma infestans was interrupted between the late 90s and the year 2000 in Brazil. And in Brazil it was in the 2005, 2006, but in Chile, in Uruguay, in Brazil, 2006, in most of the endemic area of Argentina and in Paraguay, we still have a problem there, which is El Chaco, and we still have transmission by Tratoma infestans in Bolivia, which we haven't managed to interrupt yet. But that has been a huge success. And also in Central America, the vector control of the primary vector, which is Rhodius prolixus, was very successful. Now we have another issue that in some of these parts, secondary vectors are becoming the primary vectors because of the absence of the primary vectors. But there's a lot of research in the region on vector biology and control, and we have the tools for that. We have the tools, we have the insecticides, of course, and we are also fully aware of the fact that the best way to control vector-borne domestic transmission is improving the conditions of the house where people live. So vector control has been very successful. That I don't mean that there are not challenges in vector control, but we have had a lot of achievements, and we hope that at least the same degree of achievements that we have achieved in vector control, we will in the next few years achieve in terms of the diagnosis and management of cases, for example.
Great. Thank you. Yes, sir. Please identify yourself.
Yes, my name is Jeffrey Moe. I'm from Duke University, and I'll be on a panel this afternoon about priority review voucher. But I wanted to mention that my colleague David Ridley and Nick Hammond from the International Vector Control Consortium, we have a paper that's about to be published in Health Affairs that's promoting the notion of having a expedited review for insecticides, because, as you know, resistance builds up when we do vector control, and the dynamics within the market of who's in the vector control space is shrinking. I mean, the Syngenta acquisition by a Chinese company was just announced yesterday on the heels of Xi Jinping meeting with President Trump. We'll see what comes of that. And also that there are a shrinking number of players. It's quite different than what you see here of a number of multinational companies and then many smaller companies pursuing this in terms of drug treatments. I'd say just the opposite is occurring as regards vector control and research on that. So we think there's a market failure there, and there needs to be more stimulus to promote new insecticides.
I mean, I think one of the places, I appreciate that comment, one of the places where the PRV system is not working well, in my opinion, Dr. Moe, is in vaccines, and partly because the timelines are so long, and you know that we're looking at a decade or more typically to go through a full product and clinical development plan and licensure, and what you need is upfront investment rather than that pull mechanism of the PRV. And so if you have to wait it out for 10 years to license something, then it just doesn't happen. So has there been any thought to what some people are calling partial PRVs or intermediate stage gating for PRVs to get partial funds?
I'll make one comment and then push it back to the panel. The PRV was designed to be a pull mechanism. There are other push mechanisms to give that upfront funding. We agree with you, but we're not participating in discussions about a partial PRV. I can say that people are making, well, I'll leave it at that, and I don't want to hijack this panel.
Okay.
We'll talk this afternoon.
Yes, anybody? Yes, sir.
Hi, I'm Andy Dobson from Princeton University. You can probably tell from my accent similarly that I'm not from the US. Originally, I'm from the soon, hopefully, independent nation of Scotland. Sticking partly with politics, both the rest of the UK is plainly going to have to re-look at its trade deals with the rest of the world, and they're panicking a bit about the moment. The US is going to have to do, we're promised, all sorts of tax breaks for industry. Now, it strikes me that although I know the big chemical industries have a heart, that lots of the money they're putting into development of drugs for NDTs is some sort of tax write-off or can be written off. If we're going to have a big change in the tax laws, hopefully both in the UK and very much so in the US, how much pressure can we bring to write off or get a better tax deal for doing drugs for NTDs and particularly Chagas, particularly as it's emerging as a problem in the US? And then just associated with that, I mean, I think it's fantastic that Bayer is giving 2 million doses of these pills every day, but I see from the figures that every year that there's about 5 million people infected. So you're going to need more of a tax write-off to get those extra 3 million pills to disperse.
What do I know from industry?
Just
anybody, if anybody else wants to address that also.
Just a comment on the taxes. Of course, that will be much welcome. We've been discussing this because we could invest a lot of that money in other parts of the treatment, diagnosis, and so on. Adding to the comment of enriching diagnosis, for example, we don't have that expertise, but we can facilitate conversations. And just as an example, we just created a partnership between Fiocruz in Brazil and the Novartis Foundation to create a RNA digital sequential test for malaria. So again, if we have free resources, we will invest more in other parts of the chain of diagnosis and treatment.
I think the funding definitely is a component, but I think there's also...
I'm sorry, identify yourself.
Sorry, Antonio Arshi from Novartis. I'm in charge of corporate affairs for the region. So thank you for having this, and thank you, Cameron, for organizing this. I would say definitely the financial incentives is a component, but I don't think it's the main component. There's got to be a willingness to collaborate. We need to have a fertile environment where we can actually collaborate. This means industry and public officials and local in-country institutions. My question is, where do you, the panel, see, is this being the case? Where can maybe PAHO, WHO, other types of organizations collaborate in this process? Because we are, as you can see, we have 3 industry companies here that want to drive some level of collaboration, but what else can we do? I think, how do we go from that intangible to something more tangible? How do we support the patients in Argentina, Mexico, and Brazil now?
Jessica.
I think the main area of need for support for the patients right now is simply any way to increase accessibility to treatment. I mean, we've hammered that point in a lot of presentations that regardless of what other innovations we make, patients are simply not able to access care for Chagas disease right now. And there are a whole host of reasons for that. Obviously, it's happening in, countries as wealthy and with a health system as advanced as the United States. So, our main request of companies would be to think about accessibility, not just R&D, but also how you will deliver the treatments to patients.
I've taken a big hit for this, but I still believe in it. I looked to the HIV/AIDS model, where you had this incredible grassroots patient advocacy initiative beginning in the 80s and into the 90s that promoted awareness, helped destigmatize HIV/AIDS, and got a whole generation of people on treatment. And that happened through the activist community, the celebrity community, and finally government leaders came through. I see we're about 3 degrees of separation from that for Chagas disease. You have a dearth of patient advocates. You don't really have an activist community. You certainly don't have the celebrity community engaged at all. And when was the last time you heard a prominent leader in the Latin American government speak out on behalf of Chagas disease? I can't really think of an example. I mean, we've had Mirta Rosas, Periago, former PAHO director, involved, but it's been conspicuous by its absence. So I think Chagas disease is a total advocacy disaster. It'd be nice to explore ways to address that.
If I may, I apologize. So yes, medicines is a component, but it's not the main component. I would say, to your point, if you go to the countries and you speak to the patients, there's no awareness of the disease. There's no commitment by the local health institutions to say, we are going to tackle Chagas. So I think it goes more, because we, industry, have a role to play, but we're not the only player. And so what I would say is, how do we get there? How is there a commitment? How do we drive more to those plans of action? Because people don't know the disease. They live with it for many, many years. And it doesn't, they ultimately die from a cause of other things. And the cost to the health system is incredible.
Okay, one last comment, and then we have something over here in the corner.
Slow.
Thank you. And actually, that ties in perfectly with my question. So my name is Maya Carrion. I'm from the International Society for Infectious Diseases, and I'm also a DRPH student at Boston University School of Public Health, and I'll be speaking a little bit later. But this goes to sort of all of industry. So as you can see, and I think you'll hear a lot in the second session, a lot of the people who are working on this awareness are small. We're students or we're small groups, and we've already talked about how there's little funding to go around anyway. So what kind of commitment does industry have then to help support us maybe in raising this awareness? So a lot of what my work is around is actually raising awareness and not sort of the pharmaceutical side of things. So have you looked at in your programs, I mean, I think everyone has talked about wanting to raise awareness, and both within country, I'm focused in the US, but within the Latino community. So what kind of commitment can you guys make to us to help to try to support that, being that we're small, so we don't have, I don't have a team behind me who can write huge grants or really get the attention of big people, so.
Did you bring a collection box with you?
Yep, I did. I got right in back.
You're welcome to use some of the glasses and cups.
One thing I will say that certainly from the Bayer side, we do have a mechanism for entertaining investigator-sponsored studies or activities, and I would think if a proposal came through that process within Bayer, it could certainly be considered. If we don't know about it, we wouldn't be able to consider funding anything. But so if that could be, sent into the company for consideration, certainly we'll take a look at it.
Well, apart from funding, because I think we should, talk about other ways to collaborate. I think it's a matter of, my commitment will be a matter of talking and trying to find a way to collaborate together. I don't think everything should be based on, funding. Novartis, we also have grants, donations, and investigator-sponsored trials. But I think we need to talk and we need to find common ways to collaborate. Okay, so if you want to talk later, we can discuss.
Well, I think we're out of time. It's time for a break. We have. Want to do 30 minutes? Yeah. Okay. Great. Well, thank you very much for a very stimulating morning and an excellent group of speakers today, and thank you for the panel discussion. We'll connect.